Hello and welcome to session 7 of Rhythm Interventions Online 2025. It's US Day Focus 1. I'm Jason Andrade from Vancouver, Canada, and I'm a course co-director from Rhythm Interventions Online. We have a great session for you today called Versatility of the Multi-Electrode Array, PVI, Linear Ablation, and Beyond. For this, we will have a case presentation from Dr. Devi Nair from St. Bernard's Heart and Vascular Center in Jonesboro, Arkansas. And we're also joined by our expert panelists, Dr. Vivek Reddy from New York City and Dr. Harikrishna Tandri from Baltimore. A reminder to our audience, please be part of the active discussion. You have the ability to submit your questions online for the faculty, and we'll do our best to address as many of them as we can as we move through this session. So without delay, I'd like to hand it over to Devi for the case presentation.
Thank you, Jason. All right, so for this session, I'll be talking about the multi-electrode array catheter, which is the globe catheter. These are my disclosures. So just as an introduction of the globe design, this is a catheter that has a high-density mapping features. It has 120 electrodes that are sitting on a 360-degree array. It has contact assessment features that I'll go over, and it functions truly as a single-shot PFA solution for pulmonary vein isolation. And I'll try to show some of the workflows of this catheter outside of the pulmonary veins as well during some of these cases. One of the things about the array is that unlike a balloon system where you have to be coaxial, where the electrodes, et cetera, are in the equator of the balloon. With the array, this is a more 360-degree approach where you don't really have to be as coaxial. It does come in a deflectable shape, and you can see the stable handling and responsive control. The system is very responsive to deflection, torque, movement, etc. What you actually see is you see maps on different concepts. So on the left here, you can see the map which is the map that you can create with the array. So because of the 120 electrodes, you actually get a pretty high density map in a very quick fashion, about 2,500 points per minute. You can also see the array maps, which is real time, which is what I like to look at. So on the left there, you see what's called the flow map, which is a real time 3D visualization of the array, showing you where you're navigating. You can see what's called the contact scan, which allows you to look at electrode tissue contact, and that's based off thermal-based assessments, and we'll go over that a little bit in detail. And then on top of that, on the array, you can actually see the voltage and assess the lesions or assess your substrate as you're moving along. Now, the advantage of this particular system, the way I think about it, is how it targets the tissue. Now, the electrodes on these are flat electrodes compared to cylindrical electrodes that you see in some of the other platforms. So one of the advantages is that because of the directionality of these electrodes, it's insulated on one end. It's gold-plated on one end, so it's insulated. And because it's flat, there is a directionality of energy delivery. So there's limited dispersion into the blood, so avoids things like hemolysis. And because of the way it's sitting, you also have a pretty good assessment of how that contact is. And on the left there, you're seeing black is where it's facing the vein and white is where there's contact. And that's pretty much what you would see in your contact maps. Now, regarding use of the system outside of the pulmonary veins, I will say that the IDE trial that was done was a pulsar IDE trial, evaluated this device for pulmonary vein isolation, but the system has been used outside of the pulmonary veins, and I'll show some examples as well. And you can take this array and move it into the posterior wall. You can actually create linear lesions, especially along the mitral isthmus or the CTI, because you can select the electrodes that you want to deliver the lesion to. And to me, that is the beauty of the system, is that you can select electrodes that have contact, or you can select that targeted area that you want to approach. So regarding assessment, this is one of the systems that has integrated contact assessment. So on the left here, you see what's called the flow map, which is dynamic. It's real time. So as you're moving the array within the left atrium, it measures cooling of the electrodes and identifies the pulmonary vein. So the black in the center is where you would think the pulmonary veins are, and you can kind of see that we are along the pulmonary veins. And at that point, once you see that, you can go into what's called the contact scan, which takes about a few seconds. And that's more of a precise measurement of tissue contact. And it looks at warming of the tissue after application of small amounts of current. And you can clearly see electrode tissue contact, and you can plan your ablation based on that. So the center black that you see is where the orifice of the pulmonary vein is, and the white is where you have contact, and you can create how wide your antrum needs to be. And the workflow that you will see that I use before the ablation, I start with the flow map. Then as soon as I see that I'm over the pulmonary vein, I'll stop, I'll do contact scan. I can see voltage on my array and on my map, and then I'll select where I need to ablate, select my electrodes. I can see the EGMs, and then apply pulse field energy. And once I'm done with that, you can see how we have selected those green are the electrodes that we have selected. And you can see the voltage after the ablation, of course, the EGM attenuation that's classic for pulse field. So let me go through two cases. One is a PVI workflow, because I just want to show, which is what the system was designed for. If you could please play that video for me. So what you are seeing here is the insertion of the array into the system and into the left atrium. And again, I'll show it. I think they skipped that video, but I'll show it in the next case. But it's very easily visualized on ice. I don't use fluoroscopy for my cases. And you can see the array is sitting in the left atrium. My ice is in the left atrium. I will say, as much as I use ice in the left atrium, this is probably one case that I think you can get away very easily without ice just in the right atrium. But what you saw there is us starting off with the flow map and then doing that contact scan. And then once I had the contact scan, I can clearly see which electrodes are in contact, and then select those electrodes that had contact. And we kind of started with the left inferior pulmonary vein there, and those lesion tags clearly show you where the lesion was. Now, what you're seeing there is the globe, and here you're seeing is the map. And so you can clearly see what that relationship of that lesion tag is to the next location that you're going, which is I'm navigating to the left superior. Again, as I said, you don't have to be coaxial. So all I did is take that deflection off and counterclock is just a little bit. You can see the voltage on your array. So you can see the part that I'd already ablated in the left inferior, and you can see the contact scan. It clearly shows me I have contact along the superior aspect, not as much on the carina, but the carina was already ablated when I did the left inferior. And I can see the overlap of my lesion. Now, if I wanted to optimize that further, I could just come off that and just optimize it slightly and get a different contact scan. As I said, it takes a few seconds to run the contact scan. And then you can see the post-ablation voltage. Each application is about 30 seconds. And you can see about 6 drivetrains. And you'll see once I'm done with that, I'm now navigating to the right vein. And all I'm doing is just rotating the whole system, clocking the whole system, and just kind of lifting that whole system up if I'm going to the right superior. And again, you can see on the flow map, even though I like to use ICE to assess contact for PFA technologies. This is one I think I looked just at. I'm just looking at ICE for safety assessment, but not really a navigation. But mainly I'm looking on the globe to assess contact. And you clearly saw the contact scan there with the right superior pulmonary veins in the center, and was selecting the electrodes there. Now, in this case, you can go as tight as you want with your lesion set, or as wide as you want, and then you can see after we're done with the application, you can see the voltage on your array on the left, and so you can see where that lesion tag was. And you kind of see the clear definition of where those lesions are. From there, we're moving on to the right inferior, and I'm bringing that system, just all I'm doing is pulling the system down and just counterclocking it just slightly to align it with the right inferior. And I'll let this play, and I know many of you have had experience with this system. I'll let you jump in before I go into the next system, if you had any questions or any suggestions on workflow improvements for me.
It's not.
Now, I want to say the system is commercially available in the US, and these are commercial cases.
So Devi, I think it's a great case. It's not a workflow improvement suggestion necessarily, but more the comment that, as you highlighted with the flow map, it's very easy to identify the orifice of the veins. And I find that that's the helpful piece, is that as you're moving from vein to vein, you can usually see the ipsilateral vein somewhere on the shape of the catheter, and it can help direct you. So without using fluoro, without using imaging, your catheter itself helps guide you to where you need to be. And the fact that, you have 120 electrodes around the surface of it, you don't have to worry about the coaxiality that you need with, other types of catheters where you really need to oppose in a perpendicular manner, because you get to pick on the surface where you want to deliver your lesions.
Yeah, and I think one of the other things is you don't have a lot of catheter exchanges here. It's a single catheter that is mapping and it's ablating. And of course, if I want to pace, I can do activation mapping on the globe. I can pace from the globe. I do have a CS catheter for in the heart, but I'm mainly using the globe catheter for all the pacing. And here you can see the post ablation map. I mean, obviously the concern is here you can see. I actually wanted to show this just to show how we bring it to the anterior wall, and it's easy to actually bring the globe to the anterior wall as well and get contact, because you don't really have to rotate it a whole lot. You can just use the electrodes that are anteriorly on the globe to get that voltage with just slight counterclock rotation.
No, let me just also
I'm going to move on to my, yeah, go ahead.
Oh, sorry. Let me just add one more thing. I think that, this is as close a single shot as you get. I mean, the reality is that once you position it, you identify that you have contacts circumferentially. It's really a very quick lesion. It takes
Vivek, hold on one second. Can I just have them pause this video for a second? Can you guys restart this video for me? I wanted to take this case through, but go ahead, finish your thought. I had them pause.
No, all I was pretty much done. I was simply going to say that it's a quick, I think now with the current workflow of the technology, it literally takes less than 10 minutes to isolate all the pulmonary veins, which I think is, sort of what the new benchmark is going to be. And then you can do other things, which I think you're about to show us. Sort of seem like, at least.
Yeah, it's a great segue to, let me restart that second video if you don't mind, guys. Okay, so this is actually a redo case where we're coming in and we're using the globe system to actually do the pre-mapping. And you can see I decided to kind of do the map and ablate strategy. This patient actually had atypical flutter. So I knew that I was planning on doing, flutter lines. So we actually started with the left inferior here, and you can see the left inferior vein was pretty well isolated, pretty wide antral lesion there. And you can see what I'm doing here is I'm actually counterclocking and bringing the system to the mitral isthmus. This patient has an appendage closure device, so I can see that on my eyes. And you can actually sometimes see the noise on the globe, but you can select your electrodes away from any of those devices. So unlike some of the other PFA systems where the whole PFA catheter will deliver energy, here you have very selective and prescriptive manner. So here what I've done is I've done a lesion. It's almost 4 lines from the left inferior pulmonary vein towards the mitral annulus. And the reason I started there is because my team was just getting the nitro ready. And so I wanted to show this wave analysis. You can clearly see the conduction going through there.
Sorry, Devi, can you just pause right there? Because I'm not sure that people understand.
Can you pause, please, guys?
Okay, great. Because just to orient people, so the image on the left is obviously a voltage map, and you're looking at it posteriorly. And just to let the audience know, you mapped most of the left side, but the right side just not really. You didn't really map that, and that's okay. So from a posterior view, you can see that the left veins are isolated. Oh, it's moving again. That's too bad. Okay, anyway, I just wanted to orient people. And then the other image was a left lateral view. So you're looking sort of at the mitral annulus, the lateral mitral annulus sort of head on. That one right there on the right side is the lateral mitral annulus head on. There with the cranial tilt.
Yeah, and the other thing is you can see the voltage on the array. You can clearly see the mitral annulus on the globe, and you can see that little channel that's left still with the voltage. And of course, that area needs another lesion. And what we're doing is actually it's pretty much two applications, one by the vein and one where I had that little channel go through. And you can clearly see the activation on the globe right now where I have block. You can see the whole color spectrum there with activation within the globe confirmed on the wave map as well as the
It's an interesting combination of efficiency and capability that you can, map quickly and et cetera. But it is a different type of anatomy. I mean, we're not used to seeing this somewhat more, let's say, bulbous anatomy that we have right here. But once you start using the technology, you get used to that fairly quickly, I think. Um,
Yeah, I
Also
also
think
think
in the contact-based voltage sort of collection, where you actually have direct feedback of the contacts, so you're not really collecting inside points, or when you collect voltage, it actually looks like it's a good contact-based voltage. I think it's definitely an advantage. Devi, can you comment on how involved it is when you actually select a line? Does it take a lot of time? Is it like, when you say you're designing a line, like the line that you just showed, that you drew a linear line, how much time does that take for you to say, okay, fine, this is the contact, this is the line I want, these are the electrodes that I want to select? Can you just comment on that?
you know, I think Devi may be a little bit frozen right now, but so let me just comment in her stead. So when you're doing PVI, isolating lesion sets, it's actually very quick. You go to the location and then you can select a button and the system automatically picks all the, like, a double ring and plus additional
love that.
electrodes that it suggests. And then you can always move away from that. And then for a linear lesion,
Mike?
just literally the operate. Oh, Davy's back. Okay, I was just gonna say you just literally draw two lines across, or three or four, or how many ever rows you want.
Yeah, so Vivek, thank you for stepping in. But pretty much, I think what you saw there, if you can just go back on that video just a little bit, guys. So what you saw there was us going through that posterior wall, uh, and if you're taking a large area with the current iteration of the software, it is that's good. It's very quick. Like, so if I select that area that has contact, it almost automatically picks that within a few seconds. It gives you the whole area. And you can see that's a few applications in the posterior wall there. But what I'm doing there is looking at the voltage on my globe to decide how much application I need and where I need application. But if you're designing a line, then usually, again, you're just kind of clicking, selecting a whole array or whole kind of band, and it takes a few seconds, nothing long. But it's a very different way of looking at the anatomy. As Vivek said, it's not the usual type of map we're used to. It's a kind of a globular map. But one of the cool things I saw, which I actually did not appreciate during the IDE trial, was in the commercial cases, we've started using it more. And we started looking at the maps in a more 3D fashion as well. So they have this view where you can look at the map from the mitral. Like, you almost have to think of kind of taking the mitral valve and kind of opening it up and looking at the left atrium from the mitral. So it's almost a 3D geometry of the left atrium. So here, what I've done is I've done a mitral line, I've done the posterior wall, and I've extended that right antrum a little bit. And then once I've finished this voltage, what you'll see me do here is look at this 3D view, which kind of is a way to look at the entire left atrium in both in activation as well as voltage. So here you can see I'm looking at the mitral. I'm interrogating my mitral line. One of the reasons I did the mitral first is also because I wanted to see if it's durable. And here you can see the block. On the left here is the propagation. And this is that 2D atrial wave that you see. So you're looking on the left, there is a mitral block that you see. You can see the posterior wall. You're looking straight at that posterior wall. And I think it's such a cool view. I've never seen the left atrium like this. And so I thought I had to show this. So there you can see the posterior wall. You're seeing the veins. Can you pause that for a second, guys?
So I think that like this illustrates part of the concept, but I think this is also part of the whole package in the sense that the catheter itself is slightly different in terms of how you manipulate it because it's an off-axis device and it's a harder device than, let's say, we're used to. But it also then gives us the ability to get all those unique features like that flow map that's showing you in real time what's happening around it. You can get the contact assessment, and then you can rebuild these types of maps. And so conceptually and intellectually a little bit, these procedures are different than sort of a straightforward way that we're kind of used to doing this with, Carto or Abbott or Rhythmia. And so it's a bit of a cognitive reset as you're kind of doing the procedures to understand what you're seeing and what you're trying to treat.
Can I just make a
Yeah,
comment
I
just
will
about this
say
map?
that.
Oh,
Go ahead. Yeah, go
no,
ahead.
go ahead. Go ahead and finish. I'll make a comment about the map after.
No, I was gonna say, you commented on, how it looks like a difficult catheter to manipulate, but it's not as difficult in my mind. You guys can play the video. To me, it's just like small manipulations within the atrium. It's just how you see it is very different. The visualization is different. So go ahead, Vivek.
No, I was just gonna comment on that crazy map. I'm not sure if I like it or not. I still haven't decided. But basically, what the map does is you can imagine it's basically splaying open the whole chamber and showing you to you so that the widest circle you can think of is basically around where the mitral annulus is. So everything is just splayed out. Now that also means that as you get further toward the periphery, things get stretched out in it is a non-Euclidean, let's say, way. So it's a different way of looking at the information. I still don't know if I like it, as I said, but it does give you a global understanding with a single view of what's happening.
Yeah, it's like the Mercator
Yeah.
projection of the globe, right? Like it distorts the ends.
Exactly. Exactly.
Yeah. Uh, and Vivek, you presented the IDE data, and I mean, it did show great durability. Many of, at least for me, it was the first time using the system. The learning curve to me was short, but even in the hands of the new operators, I think the efficacy rates were pretty high, probably some of the highest efficacy rates we saw in a paroxysmal population, as high as 80%.
Yeah, yeah. I mean, I will say, like, it was mostly new operators. I think I may have been the only, let's say, old operator. Maybe no, also Peter, I think. But and the durability. I mean, the clinical data looked good, but again, it was relatively sparse monitoring and follow up. But I thought what you just said is really important. This is the first multi-center trial I've seen where in the patients that came back for second procedures because of clinical recurrences, who should be enriched for PV reconnections, we had a very high durability rate. It was around 90%. So I think that what it shows you is that when you can prove contact and you're able to deploy your lesions so that they're all touching tissue, they're deploying into tissue, you get very high durability rates with this technology. And it may actually, be a lesson for most technologies.
I think it looks like
I
the
think
energy loss
there
is
might be
much
something.
limited in this sort of an electrode design, giving a flat electrode, and probably it's not even dependent on where you get into the left atrium, the transeptal axis, because you have to be coplanar with the pulmonary vein ostium to engage it. Otherwise, now this doesn't depend on it because it depends on you selecting the electrodes or whatever in contact. So probably all these advantages might give it an edge over other technologies, I guess.
Yeah, I think that that's one of the things the company has done a good job of. This thing has so many capabilities that really one of the trickiest things is trying to understand what the proper workflows are. So, for example, for PVI, I think they did an amazing job of giving you a very efficient workflow, much more efficient even than what we had in the pivotal trial. For things like linear lesions like mitral, I think they're very, very good, but I think they're going to be even additional efficiencies that we'll see over the next year. So it's a very interesting and very powerful technology, I think.
Can you just comment on one thing
This
that,
is starting.
traditionally for persistent
Yeah.
AFib, we have a multi-electrode catheter that we use to map, which is probably a high density, small electrodes, 1 millimeter electrode or smaller electrode size. Here, you have a 3.5 millimeter electrode with like 2 millimeter gaps, so slightly a bigger antenna. Are we losing any information in this process of doing this? And can you just comment on that?
Yeah, it's an interesting question. Look, there's some limitations, and it's interesting. There's some companies working on really small electrodes, trying to, sort of being able to try to make more sense of the chaos that seems to be atrial fibrillation. But then there's this approach, which is relatively large electrodes. And you can imagine a situation where, for example, you could deploy algorithms where you're saying, well, I don't care about exactly what the mechanism is right here. If everything on these big electrodes, if activation is emanating away from this location, then this must be where an area that's a source for AFib. That's obviously an approach that's being used in multiple different technologies right now. So again, this has not been implemented in this technology yet, as far as I know. But I it's a limitation maybe, but it may also not be a limitation. I guess is what I'm saying.
All right. Well, that might actually be a good final word as this session draws to a close. So I give our thanks to Devi, Vivek, and Harikrishna, and our US focused day one will continue. So please stay with us. The next session will be starting in just a minute.